Good day, ladies and gentlemen, and thank you for standing by. Welcome to today's conference. And now I would like to turn the call to Dr. Susan Carroll.
Good afternoon, everyone, and welcome to today's CMS Tribal Medicare Chronic Care Management webinar, sponsored by the CMS Division of Tribal Affairs within the Center for Medicaid and CHIP Services, or CMCS, and the CMS Office of Minority Health. I'm Dr. Susan Carroll with the Division of Tribal Affairs, and joining me on today's call is my colleague, Ashley Petticord-Austin from the CMS Office of Minority Health. The purpose of today's webinar is to provide an overview of the CMS Chronic Care Management program. The intended audience includes business office, patient benefits coordinators, and healthcare professionals responsible for time-intensive chronic care coordination and billing. This webinar will provide an overview of the CMS Chronic Care Management program and will discuss the updated program with additional billing codes and requirements. Many IHS, tribal, and urban Indian programs provide chronic care management services and don't realize their program can receive Medicare Part B reimbursement. CMS recognizes chronic care management as one of the critical components of primary care that contribute to better health and care for individuals and holds promise for reducing overall health care costs. In January 2015, CMS adopted a new service code to allow Medicare Part B payment for chronic care management services provided to Medicare and dual-eligible beneficiaries who have two or more serious chronic conditions. Medicare Part B eligible practitioners and suppliers can bill for at least 20 minutes of non-face-to-face clinical staff time directed by a physician or other qualified health professional each month to coordinate care for beneficiaries who have two or more serious chronic conditions that are expected to last at least 12 months. In November 2016, the Medicare physician fee schedule was revised to enable reimbursement for more complex and time-intensive chronic care coordination, which became effective January 2017. At this time, I'd like to turn the webinar over to Ashley Petticord-Austin from the CMS Office of Minority Health, who will further expand on this program and help us walk through today's presentation. Ashley.
Thank you, Dr. Carroll, and thank you, everyone, for having me and for your time today. We're going to start out with a review of chronic care management and what the services include, and then we're going to talk about connected care and outreach campaign to teach patients and providers about chronic care management and the new billing codes. And then we're going to hear some stories from the field. First, we'll hear from Dr. Finke of the Nashville area IHS, and then we'll hear from Red Lake Hospital and get a real-life take on CCM. Then we'll have some time left for questions and answers, and I help answer any questions that you might still have at that point. So before we start talking about chronic care management, I think it's first important to frame our discussion and focus on chronic conditions. To start, what is a chronic condition? Conditions could include arthritis, heart disease, diabetes. The list is very long. If you stop and think, you could probably think of a couple of friends or family members, or maybe even yourself, who has a chronic condition or two or more chronic conditions. It's not too hard to think of it. Diabetes and arthritis, heart disease and high blood pressure, high cholesterol, depression and cancer. The list can go on. Chronic conditions are very prevalent. You can see the stats on the slide. Half of all adults in the United States have chronic conditions. To take that a step further, looking at our Medicare population, 2/3 of Medicare beneficiaries have two or more chronic conditions. Research shows that having multiple chronic conditions can increase a person's risk for poor health outcomes, including mortality and functional decline. Research has also shown that multiple chronic conditions can lead to increased health spending. And we also know that there are disparities in chronic conditions. This comes into play for racial and ethnic minorities, but also rural populations. Rural communities can face unique healthcare challenges, including access to healthcare services, access to clinicians, a higher burden of chronic conditions, and a larger percent of uninsured or underinsured populations. So taking that framework of what a chronic condition is and how prevalent they are, we then turn to understanding what chronic care management means. So there's a formal definition on your screen. You can think about non-face-to-face time and chronic conditions as those that are expected to last at least 12 months or until death of patient. And chronic conditions place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. There are time services, and of course, the focus is that CCM is person-centered. CMS believes, like most of you probably, that CCM is an important part of better health and finding better outcomes. It also leads to higher patient satisfaction and focusing on the patient. We've heard that a lot of providers are already providing these services, and many have been for several years. But some have never put a name to it, and certainly have not been billing for it. In 2015, Medicare began paying separately under the Medicare Physician Fee Schedule for CCM services furnished to Medicare patients living with multiple, two or more, chronic conditions. CMS first established payment for CPT code 99490 to pay providers for at least 20 minutes of clinical staff time as directed by a physician or other qualified healthcare professional per calendar month. The change in recent years comes as CMS considers CCM as a critical component of primary care. So now patients will receive a comprehensive care plan, 20 minutes a month or more of dedicated medical time for phone check-ins, the ability to reach someone on their care team when they need to, and other similar services. To find out more information about CCM-related care and related care management services for physicians, there is a provider-facing link on the screen on the CMS.gov page, and that's on the CMS Care Management page. CMS has been working diligently to make rule changes that enable separate payment for more complex and time-intensive chronic care management services. CMS has also been working to significantly reduce the administrative burden by improving alignment with coding language, a simplified patient consent, and reduced documentation rules. In January 2017, CMS added separate payment for some additional CPT codes. They're on your screen, 99487 and 99489, and an HCPCS code, a G code, G0506. And that was in response to feedback from healthcare professionals across the country. So the current billing code rates are, of course, we have the G code. That is an add-on code for CCM's initiating visit for the billing practitioner's time and effort that they personally provide for comprehensive assessment and CCM care planning. And these are patients outside of the usual effort described by the initiating visit code. And there's the original code, the CPT 99490, so that's 20 minutes or more of clinical staff time for non-complex CCM. Then CPT code 99487, which is 60 minutes of clinical staff time for complex CCM. And then CPT 99489, an add-on to use with the previous 99487. Those two can go together for an additional 30 minutes of clinical staff time for, again, complex CCM. That's a lot to take in. So we made a little cheat sheet. This slide is a summary of the latest from the newer CCM codes that were created this year. So you can, we like to refer to this slide to kind of, in case we're trying to find just one piece of information about the codes or to help distinguish between them, you might find this useful. Also just wanted to make a note about RHCs and FQHCs. So first off, there are potential changes coming under the current federal review period. So do look out for more information if you're an RHC or an FQHC. Generally, these providers can furnish code 99490 at this time. So that was the original CCM code. And if you are a tribal FQHC, your CCM billing would be the same as other FQHCs. And you can participate in education and outreach that is aimed for FQHCs. And there's more on that on the CMS.gov page as well. You can find the link through the previous link. And they've had some recent webinars covering this. If you missed it or you didn't see anything about it, you can find those online as well. And there's an email box. At the end, I will give you our email, and we'd be happy to help answer any questions or direct them to other staff as needed about FQHCs and RHCs. So that was a quick focus on the actual billing aspects and CCM, and an overview of what to think about. But we also wanted to take some time, because we know a lot of you don't just focus on the provider and billing aspect necessarily, but also you get questions from patients, you get questions from caregivers, from other providers, and end up being often a good partner for CMS. So along those lines, we wanted to talk a little bit about our education and outreach campaign that is focused primarily, or solely actually, on chronic care management. So we call it Connected Care. We know that CCM is new to many patients, and many providers, while they may have already been doing these services, are surprised to learn they can actually bill for them. So it's important for us to share information on chronic care and on the billing codes that are now available. So Connected Care was developed by my office, the Centers for Medicare and Medicaid Services, the Office of Minority Health, and we're working in partnership with the Federal Office of Rural Health Policy at the Health Resources and Services Administration, or HRSA. Connected Care is a national public education campaign. We seek to raise awareness about the benefits of chronic care management among healthcare professionals and with patients, and that includes rural areas and racial and ethnic minority populations. We were actually tasked under legislation to work together to focus on these populations and provide information for both providers and patients. So the Connected Care campaign has two primary audiences, as we said. We have the healthcare professionals, and that includes physicians, clinical nurse specialists, nurse practitioners, certified nurse midwives, and physician assistants. And those are all listed as eligible practitioners. But we also look to reach Medicare and dual eligible beneficiaries who have two or more chronic conditions, and those would be the eligible patients. So through Connected Care, we do place a special focus, as we said, on underserved populations, so rural populations as well as racial and ethnic minority populations. And then listed on the screen, of course, is caregivers, because in this conversation it's so important to make sure that we recognize that important role of a caregiver. So the Connected Care campaign is a national effort, but we were able to go in depth a little bit more on a couple targeted areas. So we had the ability to choose 4 states, focusing on a rural area. So we chose a rural county as defined by HRSA, and then a more urban area, which helped us focus on racial and ethnic minorities as well, finding a very careful balance in a couple of states. So the target markets were selected from a variety of factors, namely Medicare enrollment and beneficiary data, the existence of chronic care, or chronic conditions as well as management, whether somebody had adopted electronic health records, and of course the presence of racial and ethnic diversity and rurality. If we could, we would do this kind of focus on in every county, in every state, but we are reaching somebody in each state, and we're working on efforts, events, webinars, and distributing materials in every state. So again, it is a national effort still. So the screen just kind of gives you an idea about what campaign means for our term. Connected Care includes a mix of outreach approaches. So we include paid media and earned media, social media, partnership development, and then, of course, patient and provider education. So we developed a comprehensive website on our own page, and that provides links to a number of materials and other websites that give more information on CCM. As part of the education initiative, we have lots of new resources that are available at no charge, and those are aimed at healthcare professionals, and then there are some aimed at patients. So it includes a toolkit, one for healthcare professionals, and then a separate toolkit for partners. Since partner engagement is such an essential part of our work and CMS work of making sure that a patient is actually getting the information from someone they know and trust, partnerships are important. So we've developed these toolkits to help put all the information in one place, give you ideas about what to say, where else to find more information. And then, of course, we have the actual patient resources, so a poster, a postcard, and things that can be used in the community or clinical setting. And I'll give you our website at the end where you can find all of this. As I alluded, partnerships are extremely important for us. We encourage organizations, many of you could be on this call, could be a partner, that represent healthcare professionals, health systems, rural clinics, community health centers, patients, and other organizations, maybe ones who are serving racial or ethnic minority populations, and of course caregivers, to reach out to us and get involved at the national level, the state, local, community level, wherever you fit in to the patient population. So I referenced that we had created a couple toolkits. This is just a screenshot of the first page to give you an idea. It is available on our website, which is listed on the screen, and you can download it as a PDF. So it's developed for our partners. The toolkit contains suggested activities that you could do for different types of groups, maybe who talk to a healthcare professional or consumer audiences. And the toolkit was designed to make your job a little bit easier to get information about chronic care management out to your population. So in the toolkit, we provide ideas on how you can spread the word, maybe publishing a newsletter article or a blog post, sending a blurb in a newsletter or an email listserv. Then we have social media resources. We have sample text that's written for Facebook or tweets and graphics to go along with them. And everything is offered in both English and in Spanish to help us reach a little bit wider network of consumers and partners. A similar piece is the Healthcare Professional Toolkit. That's just one of a couple that we have aimed at healthcare professionals. So the toolkit is similar to the Partner Toolkit. It has guides on how to get started with CCM, how to talk to staff, how to talk to patients, materials explaining what CCM is, who it's for, why it's beneficial, billing tips, and then links to other resources to include our fact sheets, FAQs, and the other materials that were developed for CCM. We have a testimony video, which is on our site now. It's a pretty cool 2-minute video where we actually talk to a real healthcare provider, and she tells us about how she started implementing chronic care and how it changed her practice, and then we see a little bit from her patient. So we're pretty excited about that video on our site as well. And then we have some educational materials. Of course, there's a shot of our postcard that's designed for healthcare professionals, so that's to give them an idea of what chronic care is and how to find out more information. And then, of course, our patient education resources. That's the very important second half of it. So we've created materials that are designed to be easier for a consumer to understand. The first one on your screen is a poster. So this could be a poster that is hung up in a waiting room or an exam room or another office, just giving a synopsis of what chronic care is and to help get attention from people who maybe have 2 or more chronic conditions. And then we have the postcard that's designed for patients. So this gives them an idea of what CCM is, why it's beneficial, and to talk to the doctor to find out more. And then we have some new videos. So we have an animated video that's it's very short. It's designed for patients to help explain benefits of CCM, give a short synopsis of what it is, but it's a cute and friendly video that's very approachable and to help get people's attention. And that is available in English and Spanish as well. So to think about connected care and how you could help and how you might get involved, these are a few of the ways that we've been doing things. And many of this is pieces that you could then duplicate yourself. So we hope that you could join in making this effort a success. Maybe you do newsletters to your organization to help spread the word among your colleagues. Maybe you take part in webinars or meetings and conferences that might have a provider focus. Or perhaps you do outreach directly to consumers, to patients. Could be on social media or listservs and emails. And you could probably think of ideas of how to identify patients that had 2 or more chronic conditions. Providers, for example, have approached this differently. Some providers find that they can use their electronic medical records and data to figure out who they could approach, and others have a small practice and know exactly off the top of their head who they might be able to benefit with chronic care management services. So what you do would vary, but there are a few ideas of how you could get connected with Connected Care and help patients see the benefits of chronic care management and help providers who are already doing the service to actually get reimbursed. So just real quick, we wanted to show our website. The link is on the screen again, so everything we mentioned is on the site. The toolkit, the animated videos, you can see the animated video is featured in the main section there. So that's the Dr. Smith who is featured in the testimonial video. And the website itself serves as a one-stop shop for chronic care management. It is not really the patient-facing side. We, of course, at Medicare send patients to Medicare.gov, and we've worked with that team to make sure that there is plenty of information on there about chronic care. They did a blog post on chronic care management to help drive attention to the resources and to the information as well. But this site is more partner-facing and even healthcare professional-facing. So we give all of our information here. So you'll see access to resources, tools, links to other information, and then, of course, that you could download all of the resources, the postcards, the posters, and watch the videos. If you're not as into the digital and you want paper copies of things, you can do that as well. The posters and the postcards are all available from the CMS product ordering website. So I listed the URL at the top of the screen. It's productordering.cms.hhs.gov, and you can get paper copies of our postcards and the posters, and they ship for free, they mail for free. There's no expense for an organization. So you can request, you do have to log in, and to do so you do have to request an account. So if you don't have an account at this point, you would have to just submit a request. But anybody can do that. It's not an immediate, automatic thing, but it usually comes through in a couple of days. You log in, and then you submit your order and ship it just like you would another website, where Amazon or whatnot. And again, everything ships free to you. So at this time, I will turn over to Dr. Bruce Finke. Dr. Finke is the Acting Chief Medical Officer for the National Area IHS and the Elder Health Consultant for the National Area. He also serves as Senior Advisor for us at CMS. So Dr. Finke, we'd love a few words from you before you introduce Red Lake Hospital and how CCM codes can help align with IHS and tribal efforts.
Great. Thank you, Ashley. And I promise only a few words because I, like you, am really interested in hearing from the experts who are the folks from Red Lake. I'm just going to take a couple minutes to think about this from two perspectives. One, the patient's perspective, and the other is from our facility's perspective. So first, from the patient's perspective, and from what we do with patients every day, what you all do, which was really our strength, is that we're community-based. We're tribally based. We're community-based. We work to understand our population, our community, our tribe, and the patients we serve, and to know them well, and to know who's at risk, who has complex care needs, and then to bring all the resources we have available at hand in every way we can to meet the needs of those patients at risk and keep them healthy and safe. And that ultimately is what this work is about. Care management is a critical tool for identifying those individuals who are at highest risk and most likely to benefit from this kind of focused attention. And so we do that quite informally throughout our work. You all do. Everyone all of you do that. This provides a certain level of sort of structure to that. From the facility standpoint, or from the health system standpoint, nobody on this call, nobody here who's in Indian Health is not struggling with the challenge of providing the best possible primary care with limited staff and limited staff resources, and recruitment, retention, maintaining a strong provider base. That's just an ongoing challenge for all of us. And one of the primary strategies we have ensuring access to care, providing quality primary care, is to build a really robust team, so that we can so that we bring all of our staff together to care for the patient. It's a way of providing more care. And once again, I would argue, I think many of you know that care management, bringing in care management as part of that team, is a way to meet more of the need for our patients, even as we within the staffing resources we have. And then finally, the chronic care management codes offers us a revenue stream to use as we try to build this capability of bringing the best possible care to the patients with complex needs, of building care teams that are capable of effectively managing the needs of our entire community, and maintaining access to quality care. So that the revenue side of this, provided by the chronic care management codes, is really critical for us. So we're going to move on, and we're going to hear from Red Lake Hospital in a moment. And I think what we're going to hear from them is that to do this, to use these resources available from CMS, to use the chronic care management codes to create chronic care management services, or to use these codes to support the services we're in fact providing, requires understanding the requirements, and adapting our workflows to meet the requirements. And this includes everything from clinical workflows and clinical workflows starting from the minute that our patients hit the door, with benefits outreach or registration, all the way through to the clinical team. But also includes, of course, the other assets we have are our coding and our billing processes as well. So I'm really excited to hear. I'm going to stop talking now and turn this over to the Red Lake team. Just know that Red Lake is really a pioneer in this work, but they're not alone. A number of sites, both tribal and IHS sites, are have either implemented or implementing or using, I should say, the chronic care management codes to support the care they provide. And now I'll turn it over to Red Lake so we can hear from them how you all are approaching it. Thanks.
Good afternoon. This is Commander Morin, the outpatient nursing supervisor here at the Red Lake Outpatient Clinic. So our goal at Red Lake was to seek reimbursement for the nursing services delivered in an IHS-improved patient care model and improve the health of the patients with chronic conditions. As you can see in our little model here, it's not very big, but in the middle of it is a patient, and all around it is the web of care to address all those needs, all those chronic needs that our patients have. I just want to give you a little explanation of our facility. We're in northern Minnesota. We offer primary care, OBGYN, optometry, radiology, behavioral health, dental, and clinical pharmacy. We also have a small inpatient unit, urgent care, and an emergency department. So even though we're a small IHS facility, we do have a lot of services to offer our patients. And the one thing that's unique about it is that we have a blended tribal program that assists us in that with the public health nursing and the chemical health area for our patients. Our scope of nursing care management services, we have that patient-centered medical home piece, and part of that, some of the examples that we do here in Red Lake is palliative care, transitional care management, specialty care coordination. And one of the team leaders of our green team, Angelina Restand, our care manager of that team, actually has two medical providers on that team, Dr. Lochu and Dr. Anderson. Dr. Lochu has a panel of patients of 587, and Dr. Anderson has a patient empanelment of 535. So her team consists of 1,122 patients that she manages. But I'll let her explain a little bit about her process and how she manages the chronic care patients. Hi, this is Angelina Restand, and I will go over our process. Like Commander Morin said, that the panel of patients that I have is about 1,000, but we have many that qualify for chronic care management and just a handful of them that we actually use it on. But our process starts off with a referral. The referral is made by a licensed healthcare provider. Our nursing staff, our specialty providers, pharmacy, our diabetic educator, they can all refer that patient to chronic care management. That referral is then reviewed and ordered by the primary care provider. And we place an emphasis on palliative care patients. I am on the palliative care team, and I found that it aligns really well with the goals of palliative care and goal setting and management over time. Also, recent hospitalizations and discharges and follow-ups work well with chronic care management. The next step is the consent with the patient. We review the consent together, and sometimes it's a written agreement and sometimes it's verbal. It gives the patient a great opportunity to ask questions, to either consent or decline at the time. Then we'll have the first visit in which we will review the chronic conditions, the medications, the patient goals, and create a care plan with the patient. I found this step to be really nice because it gives the patient great input into what they look for in managing their care. Generally, we give a printed copy of their care plan to the patient so that they can follow along with what our goals are together. And then our follow-up visits are as needed or as requested at this time. We don't have specific monthly follow-up. Just if the patient calls and wants to review things, we'll take the time to go over that. Say they have a new treatment or a new specialty provider that they have seen and want to change their care plan, or help with organizing outside appointments with different specialists. Any medication changes, it gives us the opportunity to educate about those medications. And then every visit, we also review the patient goals and what they're looking for and how we can help manage their chronic care. Some of the highlights that I've seen as we've been working with this is really that I've had a lot of positive feedback that the patient gets more involved with their care coordination. They have more say in where they want to go in their life. Also, using motivational interviewing helps guide the patients to achieve their goals. They can see personal successes in their goals. We can review labs and look at where they were at a year ago and see how far they've come. Some of the goals that we set are just comfort goals with the chronic conditions, so they can see that we are working towards helping make their life better. The next one is patient education. It gives us a chance to really review medication and things that they maybe feel they didn't get to review during a doctor's visit. They can go back and readdress, and we can make sure that they are knowledgeable about their conditions. And then just being kind of a resource for the patient so that they have a consistent person to call and a consistent way to get a hold of us so that we can make sure that they are on the right path. Now I'll turn it over to Angela Karnofsky, who's our billing specialist.
Hello, this is Angela Karnofsky. The billing process goes after the visit. The claim goes to the coders for proper coding and quality assurance, and then it's released to billing for the verification of the claim, which is then approved, and then the payment is within 15 days to Medicare for the 80%. They'll usually pay 80% of the payment.
Okay, so we did get some questions in our chat that we can review right now. The first one is, actually, before we go over that, we'll go over our outcomes, sorry. What we've seen just since January is that doing like a rough estimate on the patients that we have, looking at our Medicare patients, the amount of patients that generally have 2 or more chronic conditions, there was around 500 patients that would meet criteria that we could potentially have as part of chronic care management. Since we started doing it, there's been about 100 patients that we have enrolled that may or may not have had an actual visit, but that were interested in the program. And then since January, we have had 27 total claims. Okay. And then here's our email addresses if you guys have any specific questions for us.
We can answer some of the questions that are in the chat box if you want us to now. I know one of the questions was from Sherry. How does the chronic care management tie into the welcome of Medicare exam and the Medicare annual wellness exam? We currently provide those Medicare preventative services to our Medicare patients. Just wondering how this ties together.
I can start that question. If anybody wants to add in, please feel free to. But this, we actually do have an FAQ that helps to address this, and CCM would be initiated by the billing practitioner during a comprehensive EM visit, an annual wellness visit, or the initial preventative physical exam, which is more also known as the Welcome to Medicare exam. So it could be something that's initiated there, and it could be something that you obtain consent during that exam. It doesn't have to be then, but that is one opportunity. But of course, that would be billed separately, and that time is not counted for CCM services.
Okay, another question we had was...
I'm sorry, before the next question, I want to double check with Red Lake. Are you guys, so actually tell me if I'm right, but I think we can initiate these services with any comprehensive visit that includes a plan, a care plan. So it can be, as you said, it can either be the annual wellness visit or the Welcome to Medicare visit, or it can be a comprehensive visit with a care plan that's generated and a conversation with the patients about care management and about receiving these services. Is that right, Ashley? Is that right? And I'm wondering, at Red Lake, how are you all initiating? Which of those routes, or do you use all of the above to kind of get these services kicked off?
We use all of the above. Generally, it depends upon the patient's circumstances. If they're coming in for an acute issue that is going to be chronic, then we would begin those services.
Mm-hmm. Great. Thank you.
So this is Dr. Carroll. I'd like to thank Ashley, the CMS Office of Minority Health, and Dr. Finke and all of those at Red Lake IHS for organizing such a great presentation. As you will see in the boxes on the webinar, the actual recorded webinar will be posted at the cms.gov/outreach and education American Indian, Alaska Native, All Tribes Call in about a week. It takes a week for everyone to get it organized and get it posted on that website. And so that information will be available for additional review if you missed part of the presentation or you want to hear it again. At this time, I would like to include our operator, Carmen, to open up the call for any questions or comments. And I'll turn it back to you, Carmen, right now, and we'll see what questions come up and field them as we can.
Thank you. And ladies and gentlemen, if you want to ask a question, just press star and the number 1 key of your touchtone telephone. Again, to ask a question, just press star and the number 1. One moment. And we do have a question from the line of Candice Lee with Gila River. Your line is open.
Hello. More specifically, I'm actually with Phoenix Indian Medical Center. But my question is in regards to the RNs that are actually doing the care management. are these master's prepared nurses that are clinical nurse specialists, or are they registered nurses that are not master's prepared?
Hi, Dennis. This is Ashley with CMS, and I'll start, and then anybody else can chime in. So the initiation is, of course, done by the billing practitioner. The actual 20 minutes of service, for example, for the non-complex CCM, might come from that billing practitioner, but it might come from someone else. It might come from someone on what we call clinical staff.
Okay.
So clinical staff would be employees that are working for the billing practitioner or contracted to the billing practitioner. And so the definition of clinical staff that CMS uses is actually we refer you to the CPT code book.
Okay.
So that could be an RN. In a lot of cases it is an RN. In terms of if the RN needs a master's, we actually have to refer you further, I'm sorry, but to the state law. So depending on state licensure. And so that I'm sorry, I don't know that particular for you.
Okay, because that was really where my question was geared to, because as I understood it, I knew that the initial comprehensive visit did need to be done by the billing provider, but then the part about the clinical staff for me was a little bit fuzzy. I know that it says clinical nurse specialist, which here in the state of Arizona is a master's prepared nurse. But from what I'm hearing with Red Lake, it sounds like these are RNs, and I didn't necessarily see that they were master's prepared. So,
right. Red Lake, do you want to weigh in?
I was just going to take a step back. I'm sorry, just a little more on practitioner eligibility. A lot of times people think of this as being a general practitioner. It doesn't necessarily have to be. And it could also be a nurse practitioner, clinical nurse specialist, physician assistant. We often see them as the billing practitioner in these cases.
But the care management that's referred to, the services can actually be incident to the care provided by that eligible clinician. So it doesn't actually require they don't need to be providing the services. My experience is that many sites are looking at health techs or medical assistants and the work that they do around care coordination and care management. Pharmacy does a lot of, often in a lot of our sites, does a lot of care coordination, care management work.
Yes, definitely. We've heard a lot of good pharmacist stories. Thank you for bringing that up.
Yeah, and then, of course, nursing may be involved. It'd be interesting to have you all from Red Lake talk about kind of who's doing the actual care, the services that are being billed to the care management through the CCM code.
Like Angelina said, we actually have a certified diabetic educator that picks up on some of this. We have a dietitian that helps with it. We have pharmacists that help us with it, and then our care managers that assist with it too.
Mm-hmm.
Okay, it's a multidisciplinary team that approaches chronic care management for our patients so that they get that well-rounded information that they need for all their chronic conditions.
Okay. And all of that care gets bundled up into that 20 or 60 or 90 minutes, depending on how much time in a given month.
Right.
That's right.
Although I would just note to follow, and the fact sheets and our website and some of the slides go into this too, but some of these are considered complex CCM. So there are different roles depending for the billing practitioner, depending on if they're billing for complex or non-complex.
Great.
Okay. Got it. Thank you.
And it's also worth noting that if the CDE is billing, for those services as a CDE, they can't also bill for that under the CCM codes. Right? So just have to be careful with this. Never any double billing.
Correct.
And we have another question from the line of Brenda Teal with Chickasaw Nation. Your line is open.
Hello. I had a question for Red Lake as far as how they are reimbursed. Are you reimbursed at the O&B rate for this visit, or is it fee for service? Say that if you're unmuted.
Oh, okay. I know for the Part A we are the flat rate, and it's 80% of that, and then for the Part B it's for the fee for service.
And CCM is a Part B payment, so this is separate from what you're thinking of as the what you refer to as the OMB rate, which is the rate negotiated with through OMB for that is Part A services that's provided. So this is only for the Part B services, and this is always going to be fee for service.
So you do get an OMB rate, or you don't?
So every visit to clinical services at an IHS hospital, every billable visit is eligible for the flat rate as well. This is just that usually hospitals will bill both A and B for a visit, and this refers to the Part B component of the service.
Okay.
But there's no chronic care management. Chronic care management payment itself is Part B, so it doesn't involve the OMB rate. That's a Part A payment. That's visit based only.
So you're getting paid currently an all-inclusive rate and a Part B payment, fee for service. Am I understanding correctly?
Yeah.
Red Lake.
Yeah.
And is there anyone from CMS that can weigh in as far as if this is correct? Because we've asked this question a couple of different times, and we sometimes get different answers.
Hi, it's Ashley with CMS. I think unless Dr. Carroll might know more, I would side with Dr. Finke on this, because I unfortunately don't know enough about the IHS billings, but I'm going to forward the slide with our website and email. If you want to email that to us, we'd be happy to get you a answer and double check it with colleagues.
And I can't answer for CMS. This is Bruce Finke again. But what I want to point out, of course, is the chronic care management services are not visit-based services. This is the work we do to coordinate care with and for the patients that's not related to a visit. So it's not actually right to think about it. I mean, it's a separate service. It's obviously done incident to a visit, to the care provided at a visit, the comprehensive visit at which the patient agrees to receive these services. But it's not intended. It's not the services you provide when you're actually necessarily at a visit by a provider. The services can be through the phone. They can be even services that are one has to do in order to gathering all the appropriate records and organizing all of the information that the patient needs, arranging transportation, arranging other services, arranging visits. But the CCM code is valuable for us because it's a compensation, or it's revenue that we can use to support the care that's not provided through a visit.
Yeah, and I understand that from the CCM, the
okay.
professional side. I just wasn't understanding how you can get an OMB rate for those visits that aren't technically visits in the facility.
And you don't. There is no OMB payment. There's no flat rate payment for these services. These just go through Part B. There's no Part A component for the CCM services.
And this is Dr. Carroll. I would agree. This is a purely Medicare Part B code and reimbursement, which would be a fee-for-service reimbursement and not an OMB reimbursement. Carmen, any other questions?
I'm not showing any further questions in the queue.
Okay. Okay.
And I think a lot of the ones I saw coming through the chat, I think were generally answered, but the email that's on the screen, if you have any further questions about chronic care, do feel free to send us an email, and we'll be sure to get back with you.
So this is Dr. Carol again. I want to thank everybody, my colleagues, and all the participants on today's call, and thank you for your comments and your questions. As a final reminder, the CMS Division of Tribal Affairs has established a mailbox for participants on this call to submit additional questions and any feedback or suggestions for further topics, for future topics to discuss on webinars much like this. Our mailbox is tribalaffairs@cms.hhs.gov. And I want to thank you all for your participation on today's call. Thank you so much.
And with that, ladies and gentlemen, we thank you for participating in today's conference. This concludes the program, and you may all disconnect. Have a wonderful day. Speakers, please stand by.